We're just going to give a couple more minutes for people to sign in. Okay, welcome everyone. I'm Julie Flannery, Senior Regional Resource Director at Caron Treatment Centers. Thank you for joining us as we continue our complimentary webinar series for professionals, and today's topic, empowering women to find hope, healing, and strength in recovery. Today's presentation is eligible for 1 continuing education credit. We would like to thank our co-sponsor, CE Learning, and these credits with the American Psychological Association. Please note that in order to receive your credits, you will need to complete the post-webinar evaluation. A link will be emailed to you directly after the presentation. After finishing the evaluation, you will have immediate access to your certificate of completion. As a reminder, you must be on for the duration of the presentation in order to receive the credit. We will be conducting this session in webinar format. All participant microphones will be muted. During the presentation, please utilize the Q&A feature to ask any questions you may have. Depending on the volume of questions, if we can't get to your question before the end of the hour, someone from our team will reach out to you directly. Today, we are pleased to welcome 2 presenters. Jacquelyn Guthridge is the Clinical Supervisor of the Grandview Women's Program. Jacquelyn began her career at Caron as an addiction counselor on the primary men's unit in 2011. Since 2012, she has worked on the women's continuum at Caron and includes primary, relapse, extended care, and currently on the Grandview Women's Unit. Jacquelyn is a part of the trauma team and participates in ongoing education and training to increase her competency around trauma. She actively participates in recovery events that focus on reducing the stigma surrounding addiction. She is also passionate about participating in outreach events that encourage women in the field and recovery to find their voice and share their experience, strength, and hope. Josephine Tynes joined Caron Renaissance in 2014 and came to Caron Ocean Drive in 2018. Prior to her work at Caron, she was a lead therapist at a treatment center in South Florida, responsible for overseeing all clinical services as well as writing all clinical programming for patients with co-occurring disorders, receiving treatment in residential, intensive outpatient, and outpatient treatment. As lead therapist, she expanded services and introduced holistic services to the therapeutic milieu. In her therapeutic work at Ocean Drive, Josephine facilitates individual, family, and group therapy sessions and develops treatment plans to identify and address each client's strengths and weaknesses to give them the best possible and necessary tools to live the best life possible. Her system-based perspective embodies the Caron philosophy that the patient is the family and the family is the patient. In addition to her ICG-2 certification, she is certified to treat compulsive shopping, stealing, spending, and hoarding. Jacquelyn and Josephine will begin by giving us a brief introduction to our topic. Then we will hear 3 pre-recorded stories about 3 different women and what led them to seek treatment. Please note that while these stories are loosely based on situations and characteristics of patients we have encountered, the recordings are fictional. It is now my pleasure to introduce Jacquelyn and Josephine.
Thank you so much, Julie. So to start today's topic, we as women are often skilled multitaskers, taking on multiple roles throughout the day: mother, wife, daughter, business professional, CEO, household manager, personal chef, family accountant, managing birthdays, holidays, and special occasions. I don't think there's a single role that a woman doesn't take on, and the amount of times that we shift roles without a day or throughout a day is truly remarkable. So enter COVID, when all of a sudden things seemed to change in ways that we couldn't ever imagine. Mothers and fathers, but mothers primarily became homeschool teachers, were working from home, dealing with lost jobs, lost wages. Is the family healthy? You know, what's going on with the kids? What's going on with a partner, a wife, a husband? Am I doing enough? As women, I think we're constantly asking, what could I be doing better and what could I be doing more of? Which leads us to physical exhaustion, oftentimes putting ourselves last and putting everyone else in the family first. So since the pandemic began, episodes of drinking in women have increased substantially. American adults have sharply increased their consumption of alcohol during the shutdown, which was triggered by the coronavirus pandemic, with women increasing their heavy drinking episodes, which is quantified as 4 drinks or more within a couple hours, by 41%, according by a new RAND Corporation study. The CDC also reported that 44% of women felt an increased level of depression and anxiety. Additionally, a national survey found that the overall frequency of alcohol consumption increased by 14% among adults over 30 compared to the same time last year. The increase was 19% among all adults aged 30 to 59, 17% among women, and 10% among non-Hispanic white adults. And again, just looking at some more statistics, really, there was a 260% increase in drug overdose deaths in women ages 30 to 64 between 1999 and 2017, and a whopping 85% increase in the number of deaths attributable to alcohol from 2017, starting in 2007. Women are just as likely as men to develop substance use disorder and are more susceptible than men to having cravings and relapse. But oftentimes, being around treatment programs and recovery communities, we see that there are generally more men than women in treatment. We want to look at why that is and how women use substances, how they respond, and what are some of the unique obstacles to treatment that we have to address and start taking an honest look at with women. It's not as simple as being able to find childcare, being prescribed a treatment plan, and things that we can generally apply to the population as a whole. We must take a critical look at women's treatment and what each of these women need in order to obtain a successful recovery. So today we're going to look at 3 different women that are going to have their stories shared through audio. We're going to listen to the story. We're going to look at some of the key issues that are presenting to each woman. So examining each case, looking at what is the proper diagnostic measures and what are the next steps. We're then going to evaluate and come up with a customized treatment plan. And finally, we're going to look at aftercare and identify what are the appropriate recommendations for each woman in one of the case studies that we're looking at today. And we will begin with Amelia.
Hello, my name is Amelia, and this is my story. I come from a small town in New Hampshire where my parents own an engineering firm. Due to the demands of their business, they weren't really around as I was growing up. I was raised by a combination of nannies, caretakers, and private schools. When they were around, my parents did instill in me that no matter what, a perfect appearance and demeanor was of the utmost importance. During my junior year of high school, I experienced a pretty significant sexual trauma, and because of that, I wanted nothing more than to escape from my hometown and leave everything behind. That's why I was thrilled when I was accepted to the University of Charleston. I was highly motivated when I entered college, but after attending a few parties, I got swept up in the party scene and got into some trouble. During the spring of my freshman year, I met David, who was 6 years older than me and was on the verge of graduating with his MBA. I guess you could say it was love at first sight because he proposed 6 months later. Yes, I was young, but I felt it was right at the time. I really struggled with my studies as I entered my sophomore year and dropped out not too long after. David got a great job, and I moved in with him. We got married not long after, and I gave birth to 2 children by the age of 25. As David became more successful, our lifestyle changed even more. We settled in a beautiful home in a suburb along the Philadelphia main line. We were very close with our neighbors, and just when I was growing up, appearances were everything. We had these lavish block parties, and drinking was a cornerstone of fitting in. Once the children went off to school, I started sinking into a depression like I've never felt before. I really lost a sense of purpose, not having children to care for all day long. David was working longer hours, and when he was around, he'd make negative comments about my cooking, how I put on extra weight, or he'd just plain ignore me. I befriended a few of the wives in the neighborhood, and we'd have a couple glasses of wine during the day. One of them turned to me onto cocaine when I mentioned that I was having trouble taking off of some of the baby weight that was still hanging around my midsection. I loved how it made me feel, and I continued using it whenever I had the chance. I even got on board with a personal trainer who had me following a strict dietary regimen of 800 calories or less per day. Between the cocaine, exercising several hours a day, and the diet, I was in incredible shape, but I was having fainting spells. I spent a lot of time in boutiques when I wasn't working out or trying my best to find the perfect outfits and accessories to impress my husband. During one of these visits, a store employee found me passed out in a dressing room. The boutique purchases I mostly kept from David. I hid them in the basement closet after wearing them once or twice, so he wouldn't realize how much money I was spending. Although living this way was taxing, I found I was able to maintain the routine and was able to keep it private for a while. Now, with the onset of the COVID-19 pandemic, David has been working at home for several months. At first, it was nice having him around, but lately it's been anything but that. He's been accusing me of watching too much TV and is still making negative comments about my appearance. But now it's my makeup or my hair or anything else he can pick at me for. In late August, David had fallen asleep early, so I decided to go through his phone. I found some DMs from a woman who he must have been speaking to for some time, saying that he is in the process of getting a divorce and soon he'll have more time to spend with her. I'm so upset about it, but I'm afraid to confront him about it and risk my home, my kids, and this life that we built together. I've been focusing on making sure my kids are staying on track with their virtual schooling, making sure there is a decent meal on the table every night, and keeping up with my diet and exercise regimen. But it is really hard keeping it together. While getting ready for the neighborhood safe and socially distanced Halloween block party, David and I got into an argument about what I was going to wear. One thing led to another, and I finally confronted him about the affair. Things turned bad quickly, and rather than let the children see us fighting, I left to go to our neighbor's house. It was there that I used cocaine to numb my anger and drank quite a bit, so I didn't have to feel anything. By the time the block party started, I was stumbling around the neighborhood and blacked out in my own front yard. I don't remember anything from that night. David called my parents to tell them he couldn't handle my behavior anymore, and he wants a divorce. He's threatening to take full custody of the children unless I get help.
So let's take a look at Amelia. Her drugs of choice are alcohol and cocaine. Co-occurring disorder is an eating disorder. Process addictions, shopping and exercise. Underlying trauma, sexual trauma from teenage years, and we definitely see some perfectionism. Her family system, she has 2 elementary age children. Her husband has been unfaithful. Her parents are in her life, but they are far away and there's minimal communication with them. Her socioeconomic background, she came from an upper middle class affluent family. Her neighborhood and lifestyle are similar to that of her upbringing. How has the pandemic affected her? So it brought her marital issues to light now that her husband was spending so much time at home. It increased her substance use linked to anxiety and anger. It transferred her perfectionism from herself to her children and reckless behavior. So her motivation for treatment is really external at this point. She is fearful of losing her children in a custody battle, and she's fearful of losing this lifestyle, which is all that she knows. She has never been on her own before now. So treatment recommendations. We would like to recommend her to the Karen Grandview Women's Program. This is a new program at Karen in the Carol E. Ware Center. I'm very proud of this program as for people like Amelia who can be with like-minded women in a small program where she can look at her trauma, look at her process addictions, look at her behaviors. Most importantly, when Amelia comes into treatment, she is going to struggle to not be in contact with her children. And in this program, she is able to do that. She can have her phone with her. We see this as a huge barrier for women with young children. And once she enters the program, what we want to do is normalize for her some of those behaviors that are going to show up in treatment: the shopping, the eating, the over-exercising. We're going to have her have a medical assessment because we need to look at her eating disorder, make sure that it's not primary. If it's not primary, we can absolutely treat her at Karen. If her eating disorder becomes primary in that she is getting sicker physically, we would need to transfer her to a facility who could help her with that dual diagnosis, and she can certainly come back to us if that is the case. We want to do some brain mapping with our neurofeedback department because we can take a look at that anxiety and help her to learn ways to manage anxiety on her own while she is in treatment. We want to look at a 6-week length of stay at Karen because of the trauma piece. We want to get a better understanding of what type of help that she needs. The psychoeducation program, absolutely, to help her to understand that the way she responds to the world, the way she, as people might indicate, overreacts to things are likely a result of that trauma that she has pushed down for many, many years and probably doesn't even remember that it's there anymore. That 6 weeks will give us enough time to either do CPT, cognitive processing therapy, with her, or EMDR, whichever is appropriate for her through that assessment. We want to make sure that she is in a body image group, a parenting group, so that, again, we can normalize what it's like to be a woman with an addiction, to start kind of chopping away at that shame, and also to help her to work on the body image issues that also have been present since a young girl. We want her to see the nutritionist. We want her to work with our wellness staff to learn more healthy ways to feel good about her body. And lastly, the spiritual connection, because that certainly sounds like something that Amelia hasn't had for a very long time. Also, along with the spiritual connection, meditation, yoga, all of those things that she can do for herself at any time. For the family, we want the children to participate in the children's program that occurs every other month It's virtual right now. So the children can log on 1 day a week for 4 weeks when it's occurring. So it's a short period of time that the kids can stay focused and they can learn more about themselves and their feelings and normalize all of this for them. On that same note, we're going to have the husband participate in the adult family program. That would be via webinar now during our COVID times, and participate in his own work with a family therapist, and then work with Amelia through family work with the primary counselor and the family therapist. We want them to have every opportunity to reconcile this relationship if possible. I think that was it on family. So then we want to take a look at aftercare and what happens after Karen. So what happens after is as important as what happened in treatment. So we want to continue that couples work with a trusted therapist in their area. We want the husband to have his own therapist if he's willing, and the children as well. We want Amelia also to have her own therapist, and this is someone that will be set up for her before she leaves treatment, so that, because we know with Amelia, as soon as she gets home, her focus will quickly fall away from herself and be focused on her family. So we want to get her connected to alumni, to our alumni group, and to have meetings in place, whether it be AA or NA or Dharma or a combination of all of those, so that she can connect to other women as she connected with them in treatment, and she can experience that absence of judgment and continue to reduce that shame and to work on the 12 steps. Okay, we can move on to the next person, Celeste.
My name is Celeste. I am 45 years old. I'm an only child from a pretty successful family. My father was an entrepreneur. My mother was a homemaker. She passed away from cancer in my early 20s. My mother and I were extremely close, and I channeled a lot of my grief into my schoolwork. I graduated at the top of my class at NYU. With the support of my father, I began my own interior design business. We catered to elite New York clientele. The business began to grow exponentially, and my college roommate came on board to help with operations. We ended up hiring a team of 50 people over the next 6 years. Much of my waking hours were devoted to the company. We became known as one of the top interior design firms in the city, catering to celebrities and leaders of Fortune 500 companies. From a very young age, I identified as a lesbian. I don't need to make a big announcement or anything. All my friends and family knew it, and they fully supported me. I'm an active member of the Pride community in the city. I started a charitable organization to raise scholarships for the LGBTQ youth who have a passion for art and design. In my 30s, I became very close with one of my furniture suppliers, Elise. We would spend a lot of time going back to the Poconos or Atlantic City on the weekends, and we loved to gamble. Our relationship became romantic, and we were married 3 years later in Las Vegas. Over the years, the ebbs and flows of business have caused an incredible amount of stress. I found that I no longer loved what I was doing. I was constantly putting out fires and just trying to keep the company afloat. The only solace I found was in casinos, where slots and tables brought the thrill of the win, and I could ease my anxiety with a couple Long Island iced teas. I started seeing a psychiatrist who diagnosed me with generalized anxiety disorder, and she prescribed me Zoloft. Then last year, my father had a stroke 2 days after Thanksgiving. He was in Florida and I was in New York. I didn't make it to him in time before he passed away, and I was devastated. I started suffering panic attacks, and so my psychiatrist prescribed Xanax to take as needed. Combined with my increased drinking, I finally felt a sense of calm, but my business started to suffer. I was missing important meetings and deadlines. When I arrived intoxicated at a stakeholders meeting, my business partner pulled me out of the room and insisted that I sell my share of the company. Having just inherited my father's estate, I felt like I had nothing to lose, so I did. My drinking intensified, as did my time at the casinos. I achieved elite status, so many of them, I never spent a dime on a hotel room, and I ate in all the restaurants free of charge. But then the pandemic hit. I didn't want to go out in public, so I started gambling online. Since April, I've gambled away about $100,000. Elise has stood by my side through all of it, but she's had enough. I was so angry at her for giving me an ultimatum at first. She's not the primary breadwinner in our relationship, and she never has been. But I also don't want to lose her. So here I am.
So Celeste, so drugs of choice, we're going to look at alcohol and benzodiazepines, which were prescribed after the loss of her father. Looking at other addictive disorders and co-occurring disorders. So we have a process disorder, gambling, alcohol use, benzodiazepine use, and also workaholism. I want to identify how, if you look back at Celeste's story, there are different points in her life where if she wasn't drinking excessively or gambling excessively, she was working to excess. So kind of that game of whack-a-mole and what's popping up when we start to address another issue. So looking at the importance of concurrently addressing all of her presenting problems. And then we would look at the family or the underlying trauma or conditions. So grief and loss of her father, loss of her mother. We also want to look at, what does her support system look like? Right now, she just has Elise. I also want to identify loss of dreams as an underlying issue. So, losing a business that you've built up and that you are excited about and passionate about is certainly a significant loss, and it needs to be addressed. And also looking at her experience of coming out as a lesbian and what was that like for her versus what's the narrative that she's sharing with the people around her, and looking at, does she have any kind of anxiety around that experience, or is it something that she's gotten comfortable with as she's gotten older as well? So looking at the family system, the loss of both parents, both of her parents passed away, and did she ever really get to grieve? I find a lot of the time with trauma, and specifically working with gamblers as well, especially female gamblers, we're really good at sharing a story. This is what happened, this is who I lost, A, B, C, D, E, F, G, looking at, you're as if you're sharing a recipe to bake cookies, but we're really talking about a lot of significant losses and things that have happened within a family system. So looking also at the socioeconomic background, coming from a successful family herself, what are the expectations that she has placed on herself, and also what were some of those messages that were learned from her family of origin. So tying the two together of the family system and the socioeconomic expectations. And then also, what's the primary motivation for treatment? The pandemic has affected her, and she's starting to increase her gambling. She's starting to have some more discord in the relationship with her wife, Elise, and also looking at the effect when we are home with our families all day, and what's the thing that we're trying to escape from? What's the added pressure? What's the experience of not having space from even the people that we love? And tying that into her primary motivation of, Elise is really the only family that she has left, and although Celeste describes with her defenses as being the primary breadwinner, and Elise has never been that, she is able to look at it and say, but I do have this relationship with this woman that I really, really love, and I want to look at what is the primary, what's my primary purpose and what's my primary focus? Am I going to make a change so that I can continue in this relationship, or am I going to say, this isn't for me? And ultimately, as you heard, Celeste does decide to make a change and enter into treatment. So treatment recommendations would be Karen Ocean Drive. One thing that we would really want to look at is the residential family program as part of the recommendations, which I'll get into a little more later. But, looking at Ocean Drive as a program for people of influence and affluence, and given the family of origin that Celeste has come from and her own success in her business, she's going to be with people who have a similar lifestyle and have similar experiences. She'll be able to be with women and men, but primarily women who have had similar struggles, similar successes, and she's able to open up. Generally, people open up a lot quicker when we feel as if we're with like-minded individuals. We would also look at the psychological assessment and looking at R bands, so an integrated summary looking at her brain functioning, having her complete an MCMI, maybe pharmacogenomic testing to reassess the medications to see if her anxiety is being treated appropriately, looking at, if maybe there's a career inventory assessment that we would want to have Celeste complete to see, now that she has all this free time, if she's not going to be gambling, she's not going to be working excessively, and she's going to be at home, what could be, some collateral information through an assessment in addition to the therapeutic sessions that Celeste might identify as things that she could do to utilize her time in a productive way moving forward. We would also look at neurofeedback and seeing how that could help with depression and anxiety through different neurofeedback protocols to target both of those presenting problems, in addition to concurrently targeting the same issues through treatment work. Looking at specialty groups. So do we want to integrate her into grief and loss? Do we want to look at her doing some specific work around gambling, be it in a gambling group or individually, meeting with someone on the team who has gambling specific experience? And in addition to those career assessments, we also want to look at one-on-one executive coaching sessions to really come up with a concrete plan so that Celeste is able to have something that's tangible and that she's beginning to execute well in treatment and continue post-discharge and through aftercare to address the next steps in her career and passion and purpose. And another thing that we would do is collaborating on an ongoing basis with any of Celeste's previous providers as part of our treatment team, and really ensuring that it's a collaborative process and the treatment team extends beyond Ocean Drive to those who helped get Celeste into treatment, and ensuring that they're a part of the aftercare recommendations as well. And just to go back for 1 second to the residential family program, inviting Elise in to be a patient with Celeste for a week minimum. Oftentimes we'll recommend 2 weeks, where Elise would have her own treatment plan, go through her own therapy, looking at her own individualized goals, and also doing some couples work to see if she would actually benefit from some additional treatment as well, because oftentimes family members are equally, if not more affected than our identified patients. And residential family program, in addition to what I mentioned, would also include Elise living within Ocean Drive with Celeste for those 2 weeks as well. Next, I'd like to jump into aftercare. So we would look at referring her back to her home therapist, because throughout treatment, Celeste identified that as a positive relationship. And as the therapist has been a part of treatment at Ocean Drive, she's been kept up to date on Celeste's progress and has participated in some of Celeste's individual sessions as well. We would make a recommendation for a robust sober living facility in New York to look at a second phase of treatment and really integrating a step down and phase down process for Celeste, so that she's able to ensure that that game of whack-a-mole that we discussed in the beginning with Celeste's process disorders doesn't start to occur again as she transitions through lower levels of care. We would also recommend SoberLink for Celeste for increased accountability, and enrolling in Karen's My First Year of Recovery program, which provides recovery support and monitoring through SoberLink and or urine drug screens, or a combination of both depending upon the patient's presenting issues. And that would be a 12-month commitment where Celeste would have a team that would work with her and Elise to look at the accountability component of the first year of sobriety. So next, we will jump into Mandy.
Hi, my name is Mandy. I grew up just outside of Baltimore, Maryland. Both of my parents are working class. My dad's a mechanic and my mom is a teacher. I followed in my mother's footsteps and became an elementary school teacher myself. I teach 4th grade in an inner city school district in Baltimore. In my early 20s, I met Brian, who was in the military, and just a few months later, we actually found out we were pregnant with my son. We decided to do the right thing and get married, and we saved up some money and we purchased a home. Brian was deployed a few times through our marriage. It kind of put a strain on things and made things really difficult for us. So we are actually separated now. 3 years ago, when I was traveling home from school, I got into a pretty serious car accident. I had to be extracted from the vehicle. I had several broken bones, including my collarbone, some ribs, a broken leg. I needed to undergo some reconstructive surgery. I spent a lot of time in the hospital. I'm still undergoing physical therapy, and I have a lot of nerve damage, and I have a lot of chronic pain now as a result. So my parents have really stepped up, and Brian has also been really helpful in terms of caring for our son. So it's been hard, but I'm trying to do the best I can in terms of managing my pain. But things are really feeling different after the accident, especially with the onset of this pandemic. I can't go for my physical therapy in person anymore. I'm becoming more paranoid and anxious. I have been taking a lot more of my pain medications to try to deal with the pain. I'm drinking a lot more to try to help myself fall asleep. It's just been very difficult. So I'm also teaching virtually. In the days that I do have my son, I'm teaching and I'm also trying to help him with his schoolwork. He's now in first grade. So some days it can be pretty difficult. So one day in particular, I was trying to help him through a math assignment, and he was getting frustrated, and he turned around and he slapped me in the face. And I was really taken aback by that because that's not like him at all. So I proceeded to have him go to another room, and he was playing video games, and I just let him do that because I didn't know what else to do. I took a couple of Percocet to calm my nerves, and I drank some vodka. I ended up falling asleep, and he came to wake me up, and he could not wake me up. So he called 911. My parents arrived, and my estranged husband arrived, and they were able to bring me around. But when I went to the hospital, they did tell me that I have some severe liver damage due to the amount of drinking that I've been doing and the amount of opioids I've been taking. So unfortunately, they've given me an ultimatum that I do need to get into treatment and get some help, or they're considering taking custody of my son, my parents in particular. So I'm really worried, and I feel like I've hit rock bottom and I need to do something.
Okay, let's take a look at Mandy. Her drugs of choice are alcohol and opioids. Co-occurring disorder is anxiety. She has underlying trauma and chronic pain from that serious car accident that she had. Her family system is her estranged husband, Brian, and her son, who is in elementary school. Socioeconomic background, she was raised in a working class family of teachers, and she is now a fourth grade teacher in an inner city school district. Her husband is in the military, and they did travel around a bit for that. How has the pandemic affected her? So she is not only her son is participating in school at home, and she is teaching at home simultaneously. Also, she cannot have her physical therapy in person, so she is not getting any exercise at all, being within her four walls and using more and more pain medications to feel better. She's struggling with sleep. Her motivation for treatment is mixed. Her son called 911 because he could not wake her up. And I think it was at that moment that she realized that she had, in fact, hit rock bottom. So it sounds like Mandy while external events motivated her, is motivated to get sober. So treatment recommendations, we would recommend her to Karen's Women's Core programming because she can utilize her insurance at that program. Also, she can be detoxed on site, which is also covered by her insurance. While she's there, we want to do some thorough assessments, a complete medical history, to look at why she is still experiencing pain. We want to put her in the chronic pain track because she can begin to have medical massage. She can have physical therapy while she's in treatment. She can participate in chronic pain groups, so she can be around other patients who are also experiencing what she's experiencing in addition to the addiction, because sometimes that just feels overwhelming to conquer both of those things. She can also participate in Chronic Pain Anonymous while she's in treatment, which is not an addiction program. It is a 12-step program that anybody can participate in, again, with other people who have chronic pain and other people who understand how difficult it is to get through every minute of every day. We want to look at that trauma with the accident. She doesn't really focus a lot on the trauma because I think the pain is her focus and just trying to get through each day. But we want to take a look at that trauma so that doesn't become a barrier to long-term recovery for her. We want her son to participate in the children's program, and we would like for her husband, Brian, although he is estranged, still to participate in the family programming so he can learn about addiction and how to be supportive, as they will always be parents to their children together, whether or not they are together as a couple. For aftercare, so Mandy just coming in for 30 days is really just beginning, especially for someone who uses opiates. It takes some time to kind of be present, to get through that withdrawal. She may have protracted withdrawal that interrupts her programming as far as being able to get up and participate. We do see that often. So we want her to have as much treatment as she needs to have that life that she wants and deserves. We'd like to recommend her to the Renaissance program in Florida, Karen Renaissance program, which is an 84-day length of stay where she can continue to do the work that she started at Karen, Pennsylvania. It gives her time to work on her trauma, work through getting well physically, and then participate in all of the family programming that is offered there, which is going to be really important for her parents. I'm sorry, we would also want her parents to participate in the family program. We want all of her family to understand how to be supportive and how to be healthy themselves, and to understand the difference between being helpful and enabling. And the family program at Renaissance is most individualized and will help them to address all of those issues that, again, could be a barrier for any of them moving forward. When she comes back home, we want her to have a therapist. We want her to continue with her primary care doctor and physical therapy, if that were still the case. We want her to connect strongly to the Karen alumni groups, so that when she is at home working and taking care of her son, single parent, which can be very lonely at times, that she has other people, specifically other women, who understand not only recovery, but are familiar with the process that she went through at Karen as well. So just like the other women, we want her to have a very, very strong support group in AA or NA and through the alumni groups. And that's all from Mandy.
Thank you, Josie and Jackie. We are now going to move into the question and answer portion. We did get a number of questions during the live feed, which you are welcome to continue asking, and we also got some ahead of time. First question, statistics show COVID-19 related increases in addictive behaviors, especially among women. Any anecdotal evidence that COVID prompted treatment, maybe a bottom, so to speak?
So I don't have statistics for that. We certainly can look at that and get back to you. I will just say from my experience is, if I'm understanding the question correctly, is that most of the women that I've seen in treatment over the past several months identify COVID as the primary reason for coming into treatment.
And if I can just build on what Jackie said, you know, I've also heard a lot of women say, you know, I was managing okay, and then with the isolation or with, you know, the additional stress of homeschool or working from home or just changing my routine, my drinking, substance use, whatever it is, increased, and I finally like hit that point where I had to do something about it because I couldn't hide it anymore. It wasn't, you know, a semi-unhealthy coping skill. It became like a full-blown crisis.
And the lack of connections to see people on Zoom versus to see them in person. For those who had some recovery before the pandemic, were really struggling with that lack of face-to-face connection.
Thank you. How often does Karen have the significant other join the client in residential treatment? Looking at Celeste.
So I can go ahead and take that one. So we want to have family involvement with every case. That's something that is really important to us. If there isn't, you know, a traditional family or maybe say a mother, a father, a partner, a sister, a brother. So say Celeste didn't have Elise and it was just her. We'll look at business partners and things like that. But as far as the residential family program, it's as clinically indicated. So if the patient and family are willing, then we'll almost always do it. It depends on the timing. That's what I would say is really up to being clinically indicated. And with COVID, you know, we've been trying to get creative with things that are virtual, and we are allowing for local families to come in right now within driving distance, and that's something that we continue to assess as things go on with the pandemic.
Okay. How do you prepare mothers to return to a home environment that was chaotic prior to treatment, knowing it will be just as chaotic after treatment?
I can take that one, or at least start. I think one of the most important things is to develop some structure while they're in treatment. So to look at what the structure of their day can be when they return home. We all know the saying, I make plans, God laughs, but to have something kind of scripted out that, you know, kind of some structure to their day. And the other part is to help them while they're in treatment to learn how to ask for help, that's not a bad thing. That's actually a very courageous thing. And that I think is something that is always a struggle for women and always will be a struggle for women. But if we can help them to understand and to practice that in treatment, they can then start asking for help from family members even before they get home, to whatever that might be, even if it's for, grandmother to read a bedtime story to one of the kids on FaceTime, just to give mom a little bit of time, just a few extra moments. So those were the things I would add. Josie, I don't know if you have any more.
No, I think just solidifying a really strong support system and connecting to resources like what you mentioned as far as structure and routine prior to discharge. And if we're looking at a 30-day length of stay, I'm saying to like start at the second week of treatment and really integrate that in so that you have a long takeoff before someone does transition back home and they're able to practice, changing some of their routines as much as they can while they're in treatment still before they go home.
Great. How can we help address trauma if the client is not ready?
So I can speak to how we do that in treatment, and that is to normalize avoidance, because that is what occurs typically when someone has trauma, is they're avoidant about talking about it, looking at it, and just normalizing that, and then helping to get some education, psychoed on how the brain reacts and responds to trauma. And I think those things normalize it for them and at least give them some hope that what's happening for them is normal as a result of trauma, and it may not feel as scary to start to look at it then.
Okay, going back to these patients, do any of these patients have a family history of addiction?
So I can take that. When we were conceptualizing some of the cases, we did mention for Celeste having a history of addiction from her father, and I didn't bring it up mostly because of the amount of time that we had to present the case, and there was so much that was complicated. But that is something in a real life treatment experience that we would have screened upon admission, also screened in a medical history with a primary therapist, with a family therapist, and in psychosocial assessments too. And we would want to look at the multidimensional effects of a family history of addiction, across human development and also the various disciplines that interact with a patient during their time in treatment at Karen.
Great. It looks like we have time for one or two more questions. Why do you think women are more susceptible than men to cravings and relapse?
I think I'll speak to the relapse, well, actually to both of them. And I think it's because women don't know how to put themselves first. And by the time they are in that beyond the cravings heading toward relapse, it's probably too late to catch themselves, if you will. So one of the things that the most important thing to focus on and to teach a woman is that she has to put herself first, and that goes against every cell in her body. But to help them to understand that in doing that, they can help their families, and then to teach them how to recognize, in their body, because your body tells you more than your things first before your mind will. So to be attuned to one's body, and to understand what's going on, and also to have a support system to be able to recognize changes.
Great. And one more question. How does gender separate programming impact the treatment experience for women?
Do you want to take that, Jackie, or do you want me to take that? Yeah. So for one, if women have addiction interaction disorder, that is sex, love, relationships, it is difficult to be in a non-gender specific program, because then there is that, it's kind of like having a vodka bottle next to you all the time, trying to avoid those process addictions. Trauma, it's difficult for some women to be in treatment with men based on their trauma. So that separate programming gives them a sense of safety. I think they're having a little bit of interaction with the other gender is helpful, because when they leave treatment, there's going to be opposite sex out there. But all in all, just that safety piece of being able to be comfortable in their environment and while they're being educated.
Great, thank you. Josie, are you able to do the wrap-up slides?
Yeah, absolutely. Caitlin's going to pull them up, and we will take a few steps back. So one thing that I really want to focus on prior to us concluding our time together here is gender-specific treatment is critical, but that on its own isn't enough. As you saw through the case studies, each of the women had very different individualized needs, different family systems, different socioeconomic backgrounds. So we really want to look at, is the program that we're going to recommend for a woman age appropriate? What is the current demographic within the therapeutic milieu as far as age? Looking at someone's identity, how that's developed over the lifespan, and really looking at, are there shared experiences with other women that are in the program, or historically, does the program have the appropriate infrastructure, so to speak, for each woman that we've discussed today and in general. So, does someone need gender-specific treatment? In that case, I would say, hey, Jackie, I think this case is a better fit for you. Why don't we have them start up at the Grandview Women's Program, and when they're ready to have, the opposite gender integrated into their treatment, maybe they can then do some aftercare at Ocean Drive, and really looking at what the best fit is for each person. And also looking at underlying co-occurring disorders and what are the most common co-occurring disorders with women. So looking at eating disorders, depression, anxiety, trauma, over-identification with roles, any kind of difficulty also putting yourself first, as Jackie mentioned before, and then looking at underlying trauma and making sure that we're really meeting each individual where they are, as Jackie described when she answered the question regarding treating someone who is maybe more resistant to look at their trauma, and are we going to implement the appropriate modalities and treatment recommendations for the individual and for the type of trauma that they've experienced. So what's really important for us to do during the pandemic? It's really important for early intervention. The old adage of your bottom is when you stop digging, right? So not waiting for something really tragic to happen, that if you are concerned about a loved one, or you're concerned about yourself, or if you're a professional and you're concerned about one of your clients, early intervention is key, especially during the pandemic. A lot of individuals that I've worked with have said, hey, it's really the perfect time. Everyone's on Zoom or WebEx or Skype or whatever it is, and no one really knows that I'm here. So I can, do my business meetings or FaceTime my kids or whatever it is that I need to do, and be in treatment because I'm not physically missing from anywhere. Looking at appropriate support systems is also really important, which I think for behavioral health and substance use as a whole has been particularly challenging during the pandemic. So really finding a way to be creative when connecting people to support systems. If it's online, can you have a group of alumni create a meeting together? That's something that we had some alumni do that was gender specific, that came out of the pandemic, in addition to our alumni services. And then also it's a lot easier to attend meetings and to get therapy and get counseling, because you can do it from any screen you have. If it's a phone, it's a laptop, it's a tablet. You don't even have to leave your house. You can do it after your kids go to bed or in the morning, whatever works for you. You're able to really cut out some of that travel time. So really, as difficult as this has been, the time to get help hasn't been, and this is the most accessible I think it's ever been. I was going to say it hasn't been easier, but I don't know if asking for help is ever easy. So I think it's the most accessible that it's been for for those of us who are looking to have some self-improvement and enter treatment. And back to you, Julie.
Sure. Thank you again to Jacquelyn and Josephine for presenting today, and to all of you for joining us. As a reminder, today's presentation is eligible for 1 continuing education credit. An evaluation will not come up directly after the webinar is over. You will receive a link to your email. Upon finishing the evaluation, you will have immediate access to your certificate of completion. We hope you will join us after the new year for more great webinar opportunities from Caron Treatment Centers. Watch your email or visit www.caron.org/webinars. And please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding any admissions to Caron's programs. Thank you for joining us and have a great afternoon.